Hello again. So in this section, we're going to talk about the current treatment for acute and recurrent pericarditis. And I thought we would try to have a little fun with this because it's getting late in the day. So I'm going to present a case, and the patient we're going to discuss is a 48-year-old tax collector who presents to the hospital with 1 day of pleuritic positional left-sided chest pain. On physical examination, the blood pressure is 122/76. He has a mild fever of 37.4 degrees. He has no jugular venous distension. His lungs are clear to auscultation. And on cardiac exam, he has a pericardial friction rub. And I don't think the audio is playing, so I'll impersonate it. It sounded like this. And his extremities had no peripheral edema. Here's his electrocardiogram, and I think you can see that there is diffuse ST segment elevation and a little bit of PR segment depression here at lead 2. His inflammatory biomarkers were elevated. His C-reactive protein was 68, with normal being less than 5. His cardiac troponin T was not elevated, and his creatinine was normal. His echocardiogram demonstrated normal left ventricular size and contractile function and a very small 2 millimeter posterior pericardial effusion. So he was diagnosed with acute pericarditis, and his symptoms and the electrocardiogram responded promptly to oral ibuprofen, a non-steroidal anti-inflammatory drug, which was continued for 3 weeks, and he felt fine during that time. However, another 6 weeks later, he returned to his physician, again describing identical pleuritic chest pain, fever, and the same ECG findings that I showed you a moment ago. His CRP level increased again to 48 milligrams per liter, and his echocardiogram continued to show a small pericardial effusion. At this point, the physician thought he had refractory pericarditis and prescribed prednisone, a glucocorticoid, 60 milligrams daily. And again, the patient responded quickly, his symptoms disappeared, and his fever resolved. He underwent rheumatologic and infectious screens that were negative for other secondary causes of pericardial disease, including a recent negative skin test for tuberculosis. His prednisone was tapered over the next 2 weeks. And after the dose was reduced to 15 milligrams daily, his symptoms of pericarditis reemerged again. So he had his 3rd episode of pericarditis. And this tax collector was not happy at this point and was threatening to investigate the hospital. And so his prednisone was increased to 60 milligrams once again, and he was referred in for consultation. So this is a patient who displayed recurrent episodes of pericarditis, and we're going to talk about the acute management of pericarditis and those patients who demonstrate recurrences. So more than 85% of patients who experience pericarditis have it on a post-viral or idiopathic basis, and this is usually a self-limited condition that resolves on its own within 1 to 3 weeks, with or without therapy. But what's important to recognize is that up to 30% of patients develop recurrent symptoms of pericarditis over the next year. The only published guidelines to treat acute pericarditis were published by the European Society of Cardiology in 2004, and that publication was based largely on opinion because there were no large-scale studies performed prior to that time. However, in recent years, there have been prospective trials that offer evidence-based guidance to the management of acute and recurrent pericarditis. And the main therapies that we now use to treat acute pericarditis include aspirin and other non-steroidal anti-inflammatory drugs, colchicine, the anti-gout agent, and glucocorticoids. And let's discuss the risks and benefits of these drugs. First of all, with respect to non-steroidal anti-inflammatory drugs, there are no prospective randomized trials showing their benefit. We simply know they work by experience. And these can include aspirin in high doses, ibuprofen or indomethacin, and parenteral therapies such as ketorolac, which can be administered to patients who don't respond otherwise to oral non-steroidal drugs. Typically, we recommend that patients be treated acutely for about 2 weeks, followed by a slow taper. Now, if the symptoms or the patient's fever persists for more than 1 week, then one should consider etiologies other than post-viral or idiopathic pericarditis. For example, in a study performed by Imazio and colleagues in Italy, they studied 254 patients with acute pericarditis who were treated as outpatients. And 221 of them responded rapidly to non-steroidal anti-inflammatory therapy and presumably had idiopathic pericarditis. But 13% of the patients had persistent symptoms over that time, and they were later found to have other causes. 14 of them had an autoimmune disorder, and 6 had tuberculosis in this Mediterranean population. The other form of therapy that's become very popular to treat pericarditis through the world is colchicine, the drug typically thought of as a gout treatment. And colchicine is derived from a crocus plant called autumn crocus, or Colchicum autumnale. And this is a plant which grows in temperate climates throughout the world. And extracts of this plant were used to treat gout as early as the 1st century AD. So it's been used for 2,000 years. In colchicine, the active chemical was first isolated from a plant in 1820 by French chemists. And in 1987, Dr. Rodriguez de la Serna in Barcelona, Spain, came up with the idea of using colchicine to treat pericarditis because of his experience in seeing the benefit of colchicine in treating serositis in his patients who had familial Mediterranean fever. Now, the mechanism by which colchicine is thought to be effective as an anti-inflammatory and in pericarditis is shown here. Colchicine interferes with a self-assembly of microtubules in the cell. Microtubules are critical for multiple cellular functions. And colchicine binds to these monomers of tubulin, which self-polymerize to form microtubules, and prevents that from occurring, so that microtubules are not correctly formed. And colchicine accumulates in white blood cells by 16-fold compared to circulation, and is thought to interfere with inflammation through interference with microtubules by preventing appropriate neutrophil motility to sites of inflammation, impairs phagocytosis of white cells through altered expression of cellular adhesion molecules that attract leukocytes to sites of inflammation, and by impairing mitosis, division of the cell, through impaired spindle formation during mitotic division. Now, there are a few main trials that have used colchicine in a double-blinded fashion to test in the therapy of acute pericarditis. The first is known as the ICAP trial, and in this study of 240 men and women with their first episode of pericarditis, the patients were randomized to either colchicine in small doses, not the high doses that are used to treat gout, but in small doses of 0.5 to 1 milligram a day for 3 months versus placebo, in addition to a non-steroidal drug such as aspirin or ibuprofen. And the primary endpoint was to assess for persistent or recurrent symptoms of pericarditis. And the main result of this study is shown here, where the probability of event-free survival is shown on the y-axis, and months of follow-up is shown on the x-axis. And you can see that compared to the patients treated with placebo, patients who received colchicine had a much lower risk of recurrent pericardial symptoms. It was reduced by about half. And symptoms at 72 hours after presentation was also reduced by about half among the patients who received colchicine. A second study, known as the CORP trial, was one in which patients were randomized who had already experienced the first episode of pericarditis. This was a prospective, placebo-controlled trial at 4 urban hospitals in Italy, involving 120 men and women with their first recurrence of pericarditis. They were randomized to similar doses of colchicine basically 0.5 to 1 milligram a day for 6 months versus placebo, in addition to their non-steroidal anti-inflammatory therapy. And again, the primary endpoint was to assess for recurrences of pericarditis at 18 months. Here are the results of the trial. Y-axis shows the event-free survival versus months of follow-up on the x-axis. And compared to the placebo-treated patients, those who got colchicine, again, fared much better with a much lower incidence of recurrent pericarditis. Now, you might be wondering how well was the colchicine tolerated, because when patients take colchicine for gout, often they're troubled by diarrhea and other symptoms. But that was not the case in these studies where low doses of colchicine were used. In fact, the differences in side effects between placebo and those who received colchicine were the same. There was no significant difference in terms of gastrointestinal symptoms, hepatic toxicity, or muscle toxicity. The same number of patients withdrew from the trial as took colchicine as had taken placebo. So it was very well tolerated. So colchicine has now become a standard therapy for the treatment of acute pericarditis, both to reduce symptoms acutely and to prevent recurrences. The third type of therapy that's used to treat acute pericarditis are glucocorticoids like prednisone. And you probably have all had experience using glucocorticoids in treating pericarditis. They're very effective. They rapidly improve symptoms. However, they should not be used as primary therapy for pericarditis because the presence of prednisone therapy increases the risk of future recurrences. For example, in this meta-analysis, this study showed patients with acute pericarditis who were treated with steroids versus those who weren't. And on the y-axis, again, is event-free survival, looking at recurrence rates of pericarditis versus years of follow-up on the x-axis. And compared to the patients who did not receive corticosteroids as part of their regimen, those who did receive steroids for either a short term, less than 3 months, or a longer term, greater than 3 months, the incidence of recurrent pericarditis was much higher among those patients who received steroid therapy. In addition to that, in multivariate analyses, not only did glucocorticoids increase the frequency of recurrent pericarditis, but they blunted the effect of colchicine in preventing recurrences. This was identified in a study known as the CORE trial in patients with recurrent pericarditis, in which aspirin was compared to aspirin plus colchicine in the prevention of recurrences. And in that study, just like the others I showed you, aspirin plus colchicine resulted in fewer episodes of recurrent pericarditis than aspirin alone. However, in that study, there were some patients who were aspirin intolerant because of allergy, and those patients received prednisone instead of aspirin. And the patients who received prednisone instead of aspirin plus colchicine had a recurrence rate of pericarditis that was no different than patients who received aspirin alone, and much worse than the patients who received aspirin plus colchicine. So prednisone actually got in the way of colchicine of preventing future recurrences. The bottom line here is that although glucocorticoids are effective in the management of pericarditis, they should only be used when patients are truly refractory to or intolerant of a non-steroidal anti-inflammatory drug plus colchicine. Now, if steroids do need to be used for treatment of pericarditis, which happens when patients don't respond to these other regimens, the question is, what should the dose be? Because the experience historically has been to use 1 milligram per kilogram per day, roughly 60 milligrams of prednisone a day, and that's where we seem to run into trouble with recurrent disease. So this was a retrospective review of 100 patients comparing a lower dose of prednisone compared to the standard regimen. So a dose of prednisone of only 0.2 to 0.5 milligrams per kilogram per day, compared to the standard regimen of 1 to 1.5 milligrams per kilogram per day, followed by a slow taper. The bottom line from this study is that the lower dosage was effective and associated with fewer side effects and associated with less recurrent pericarditis and fewer hospitalizations. And that's shown here, again, Kaplan-Meier plot of event-free survival on the y-axis versus months of follow-up on the x-axis, compared to the patients who received high-dose prednisone. Those who got the lower dose had fewer episodes of recurrences and fewer side effects associated with steroid therapy. So it is recommended that if you do need to resort to the use of prednisone in the management of pericarditis, that a lower dose than has historically been the case should be used, a dose of about 0.25 to 0.5 milligrams per kilogram per day, to continue that dose for 2 weeks, and then to slowly taper the regimen off. So between 25 and 50 milligrams of prednisone a day, the tapering would be 5 to 10 milligrams every 1 to 2 weeks. And as you get closer to the dosages at which pericarditis tends to recur, 15 to 25 milligrams a day, the tapering should be even slower, 2.5 milligrams every 2 to 4 weeks. And then once one gets below 15 milligrams a day, that's when recurrent disease tends to manifest itself the most. The tapering should slow to a very low level of about 1 to 2.5 milligrams every few weeks thereafter. And this is a regimen that tends to be very successful at getting patients off of steroids without increasing the recurrence rate. Now, there are patients who are treated with steroids who simply can't get off the drug because they keep getting recurrences. Again, the trick is to use a very slow prednisone taper and to remember to add back non-steroidal anti-inflammatory therapy and colchicine when the prednisone dose declines below 20 milligrams per day. And then, if necessary, and this should be very rare, but if patients can't get off steroids because of recurrent episodes of pericarditis, then other steroid-sparing therapies should be considered. And what is recommended on this slide is simply from case reports and non-randomized data, because there are no prospective strong studies showing their benefit, but we do have some clinical experience showing benefit with steroid-sparing agents such as methotrexate, azathioprine, IV immunoglobulin, and the interleukin-1 receptor antagonist, anakinra. And then finally, if patients have truly refractory pericarditis that keeps coming back, we would consider them for pericardial resection. So the teaching points from this section is that the primary therapy for acute pericarditis should include a non-steroidal anti-inflammatory drug for about 2 weeks that then gets tapered off. One should consider the use of colchicine, especially to prevent recurrences, and if you can, try to avoid steroids because they increase the recurrence rate of pericarditis. So it's getting late in the day. Thank you very much for your attention, and we'll stop there.
Thank you, Professor. I think it's a very interesting presentation. Personally,